thrombus aspiration just can't seem to get a break. It was 1 year ago at the ESC 2013 meeting that the TASTE trial results were first reported. And now in the September 16 issue of JACC, it's results of the TATORT-NSTEMI thrombus aspiration trial. And one more time, we're here with Dr. Sanjit Jolly, MD, McMaster University, Hamilton in Canada. And you're leading another trial. This one's called TOTAL, that may offer a more complete answer. First off, this has not been a good year for thrombus aspiration. Do you have any problems with like the TASTE trial or any of the data that's being presented?
I mean, I think that's a good question. People had a lot of expectations that TASTE would be completely different at a year than at 30 days. And I think the message is, this is not like an ongoing drug therapy like ticagrelor. This is a one-time intervention. So if you don't see a benefit at 30 days, or at least an emerging trend, quite significant, it's unlikely that you're going to see a big effect at a year. So I think people were very enthusiastic that we might see a difference at 1 year, but I wasn't surprised. I think that one of the key issues with TASTE is, while it was the largest trial, for mortality it was underpowered for modest reductions, 20 to 30%. So I think people really have to wait, and we have an event-driven trial, a trial of nearly 11,000 patients upcoming, the total trial. And hopefully we'll have results in early 2015 for that trial.
I mean, originally it was a smaller trial, wasn't Total? And then then you decided you wanted to make it a bigger trial. So why the change in size?
Yeah, so it's an event-driven trial. So we had specific time points where we look at the number of events. And we had initially planned to recruit 4,000 patients. And the patients are doing better. And I think one of the important things is it's not the number of patients that's in a trial, it's the number of events that it actually preserves your power. So by doing an event-driven trial, you actually make sure you have the requisite power to show a difference. And I think one of the things, the most common thing that we do wrong as physicians is we do underpowered trials. So we had trials with 50% power, and then essentially it's like flipping a coin to whether you're going to see a true effect or not. And unfortunately, we're probably wasting our time and everybody else's time doing those trials, because we probably should all work together and do the big trials like the ISIS-2 trial, you know, those early big STEMI trials that really showed that aspirin had a 22% reduction in mortality.
After the failure of TASTE, did you have any trouble getting new patients to enroll in this trial in Total?
Actually, recruitment increased after when.
Oh, wow.
So, you know, because physicians were feeling that once they saw thrombus, it was an absolute requirement to pull it out.
Right.
So there was a reluctance to participate in Total. But when TASTE actually brought more equipoise, that, you know what, this is not a religion. You know, if you don't do this, you're not going to hell. It actually was very helpful for the Total trial too, and our recruitment actually increased. So.
Wow. Okay. Now, until the Total trial results come out, what's the lesson? Is there a lesson for the clinician?
Yeah, I think the lesson for clinician is, if you see a huge effect size in a relatively small single center trial, it's too good to be true. I think the second important thing, that anything that we do is going to be fairly modest. So, you know, trials of, if a relative risk reduction is in the range of 20 to 30%, believable. Beyond that, there's very few things other than perhaps TAVI that in the modern era that have improved outcomes so much.
Well, if you want to read out more about the TATORT-NSTEMI trial, that is the September 16th issue of JACC. And if you want to know more about the Total trial, you're going to have to wait just a little bit while, till 2015 probably. For CardioSource World News, I'm Executive Editor Rick McGuire.